Thank you so much indeed for joining us. We wanted to get the local football stadium, but we have to actually do with this one. So apologies for this. If you wanted to, you can come a bit more to the front if you wanted to, hear us all and see us all. This is the poster session and we're going to kick off now. We're still waiting for a couple of contributors. But I just wanted to start the session. I'm Axel Kehne, Professor in Health Services Research at Sturt University and editor of the Journal of Integrated Care. And I'm absolutely delighted to be joined here by some of my colleagues, international colleagues from across the world. And this is a poster session, so what we do is each of the participants, each of the contributors will speak for about 10 minutes. And what we do is we start with Céline, if that's okay. But we have a slight hiccup today, and I wanted to just have a show of hands in the audience. Who of you speaks Spanish? Can I have a show of hands? Okay, 3, 4, okay. Oh, 5, there we go. And who of you speak actually French? Can I ask you? French, show of hands. There are more French speakers here than Spanish, so I'm really sorry the Spanish are losing out today. So es francés, okay, so that's possible. Okay, brilliant. We have, unfortunately, with Céline's colleague, couldn't be here, and she wanted to present in English, but because she can't be here, Céline will present, and she will present her first poster, this first poster in French. I hope that's okay with everybody. And then we'll continue, of course, in English. So please bear with us. If you don't speak French, bear with us. We're going to have two English-speaking presenters later on as well. So the floor is open, Céline. This is your job. Okay, thank you very much for joining. And we hopefully get the presentation, the poster up on the screen, if that's okay. Can we get it up on the screen? Is that a possibility? Is anybody there? Okay, we'll sort that out. Voilà. Thank you.
Voilà, bonjour à tous. Désolée pour l'anglais, c'était ma collègue qui devait présenter en anglais, mais elle est malade. Donc voilà, je me présente, Céline Mostade, donc je suis pharmacienne de formation. Et je coordonne le partenariat Integrated Care en Belgique, en province du Luxembourg. Donc c'est de l'autre côté de la Belgique, dans le sud. Et alors nous, on a travaillé sur beaucoup d'actions pendant 5 années, même dans le cadre des projets Integrated Care en Belgique, dont un des projets qui a été une des portes d'entrée vers l'intégration des soins, ça a été l'activité physique adaptée, où on a travaillé sur la province complète, donc 44 communes, où on a essayé d'implémenter avec les médecins, les kinésithérapeutes, les ergothérapeutes, de l'activité physique comme traitement non médicamenteux, où on a établi tout un parcours de soins avec les différents acteurs aussi des communes, les acteurs des plans de cohésion sociaux, les pharmaciens, les travailleurs du domicile, où dès qu'il y avait une personne sédentaire, elle faisait une activité, un bilan d'abord pour établir sa condition physique, et puis elle était envoyée vers un parcours d'activité physique adaptée avec des professionnels qui avaient été formés par nos soins, où pendant 12 à 14 semaines, il y avait des cours collectifs, donc on a eu presque 300 patients qui ont participé pendant une année à nos différents modules. Nous, on a arrêté ici cette année de coordonner sur le terrain, mais ça a été repris, où on est encore en train d'étendre les activités physiques adaptées. Et ça a vraiment été une porte d'entrée, puisqu'après, le médecin et le kinésithérapeute ou l'ergothérapeute se revoyaient pour évaluer la condition physique des patients. Et on a ajouté après à ça des consultations de psychologie, d'entretien motivationnel. On a ajouté de la diététique dans le parcours et donc ça a vraiment permis un travail d'équipe autour de l'activité physique adaptée où on a eu vraiment une adhésion des médecins beaucoup plus facile parce qu'on était vraiment dans des cas pratiques qui répondaient aux besoins des patients et des médecins. Donc voilà, on a conclu après une année. Et là, on est en train d'essayer de faire reconnaître ça par les autorités belges, puisque ce n'est pas encore dans la loi belge de pouvoir faire de l'activité physique de groupe sur prescription médicale. Donc voilà.
Thank you, Céline. Okay, fantastic. Any questions? Anything you want to ask Céline? We have a chance here. Of course, I can't promise to translate, but you're fluent French speakers in the audience. Okay, fantastic. Thank you so much, Céline. Much appreciated. Merci beaucoup. Okay. And we move on. We have Russell here now, and Russell will present his poster now. The floor is yours, Russell.
Thank you, Axel, and thank you everybody for attending after lunch. You know, ours is a system approach, and fundamentally, the question is, you know, what do you do when a big proportion of your population is suffering substandard care and you've got a fragmented and siloed health system? How do you deal with that? And essentially, with Equally Well, this is you know, what we were confronting. So Equally Well, for example, and my example is the physical health of people living with mental illness. For those who don't know, people with mental illness suffer far worse health and internationally die between 13 and 23 years earlier than the general population, mostly from preventable chronic diseases such as cancer, cardiovascular disease, diabetes, etc. So even of the 10 most predominant chronic diseases, 10 times more people die every year prematurely of that preventable chronic diseases than suicide. So the major risk of early death for people with mental illness is not suicide, it's chronic conditions. This is not fair. This is not equal. An example of this is in Australia. Every single day in Australia, a population of 27 million, 16 people with mental illness die prematurely because of cancer. If this was a population rate, if people with mental illness had the same equal rate as the rest of the population, it would be 2 people a day. This is why we're talking about Equally Well. This is why we have this national movement of Equally Well. So the question is, given the research around this, and there's about 15,000 controlled trials demonstrating this. There's 132 so far and counting reviews, meta-reviews and meta-analyses, which show that the health inequity gap. So what do? Well, we try and chew gum and we walk and we juggle at the same time. So this is the approach of Equally Well, and in Australia, and I don't think it's that different to a lot of other federated systems, in Australia we have a fragmented system. We have the state public health services, we have private services, private hospitals, GPs and psychologists who are private, they're small businesses, so they're privately funded. We also have community managed organisations who deliver health services and mental health services, and not-for-profit organisations. We also have the professional colleges who are responsible for professional practice of GPs, psychologists, social workers, 14 of them. And we also had, of course, the advocacy peaks, people who are looking after the representing carers and consumers generally. And we also, of course, have the organisations for chronic conditions such as cancer, cardiovascular disease, diabetes, etc. This is our fragmented system. And I don't think it's that unusual. Talking to people at the conference, a number of other countries have similar issues. And also, the training is siloed. You have an oncologist, a psychiatrist, a GP, occupational therapist. Often, everything is going towards fragmentation. So how do you deal with that at a system level? Well, we're having a go at 3 different levels. I'm just going to use the mouse because we're streaming this. At the macro level, at the meso level, and the micro level. When you chew gum, walk, and juggle. So at the macro level, and I can't emphasise this enough, in Equally Well Australia, you start off to develop some consensus. So we spent a year developing a consensus statement, a consensus document, consulting with all those stakeholders we were talking about, and developing a national consensus framework, which I was privileged enough to steward and to author. And now we have about 100 organisations, every government, every professional organisation, all the peaks and most of the chronic care, who've signed up to say, yeah, this is a problem, and we commit to do something about it. That's number one. And influencing the authorising environment. So we've managed to get that into the National Mental Health Plan. We've managed to get that into the Product Commission inquiry recommendations, Start Now, and priority reforms. We've managed to get that into the new national agreement. This is tremendously important because this is your authorising environment, and this gives you the leverage when you start working at the other levels, at the systems level. Do you know you're committed to this? Can we help you work together? So Equally Well is a collective impact approach. In our view, it's the only way to work through fragmented system is to get all the fragments of the system to agree for a shared agenda and a common goal and start to work together. We're now working with the cancer. We've been successful with smoking to make mental health. This is part of general care. If you're about smoking cessation, you should be thinking about the high-risk groups, such as people with mental illness. We're working with the Cancer Foundation, the Australian Cancer Plan, and it's including a recommendation to implement the 48 actions of the Equally Well consensus statement. So we're trying to get this into mainstream. We're now working with the cardiologists as well. New Zealand have been tremendously successful on this. We're still working with it. So we're trying to get into the authorising environment of everyone who can have an impact. Not just mental health, not just GPs, but the specialists as well, because it's everybody's business. It's a systemic problem, so you've got to implement at every part of that. That's the macro level that we're trying to attend to. And I can't emphasise that enough. That's hard work. You need to get the collective, the academics, the researchers, the people with lived experience, the place-based expertise, all advocating to get this into whatever the planning and authorising environment. Once you do that, then you can work at the meso-level systems. So the systems, the networks that provide services, to work with those networks to say, how are you going to make this real? You've signed up to this. How are we going to make this real? And it's different for different organisations. So, for example, we've worked with a number of the state governments have implemented this and put it in their key performance indicators for their directors, and more particularly for their whole system directors. Within each of those things, there's about 50 other systems. So each of those chief executives, it's a KPI. Once you do that, once you get the chief executive, another part of the authorising environment, saying, yes, we've got to do this because it's in my key performance indicator, then you're starting to get some traction and you can work with the people at system level. So we've got a number of the states and systems and working through. Once again, it's not a one thing. The picture on your left there is about older persons' mental health services across New South Wales, population of about 8 million, worked for about 2 years to change their practices around integrating the physical health for people, older people with mental illness. The state government's doing that as well. We also work, with our conferences, just like this, but also with our ambassadors. We have an ambassador program in each. If we think of the system, in a way, you've got this universe of health services, and then you have these constellations. And one of the constellations are professional groups. And so we have our ambassadors in each professional group, the GPs, the psychiatrists, the OTs, the consumer advocates, the carer advocates, the physical exercise specialists, and they work within that constellation, within this broader universe. And that's how we try and work across at the meso level. And whilst I said it was important, the micro level is also important. I've done a lot of flying recently, and one of my best friends is a systems engineer for Boeing. I'm very comforted to know, he tells me that all jet airliners have triple redundant critical systems. So in other words, you're about to take off, something fails, another system comes into thing. If that fails, another system comes into play. Well, I think we need that too in service implementation, a triple redundant critical systems. And one of the critical systems are the clinicians and the consumers themselves. So the other thing that we look to do is to empower and equip clinicians. Doesn't matter what the authorising environment says, doesn't matter what the system says, empower consumers to get the care they deserve. So we have a number of projects doing that, which is very complicated. It's co-designed, it's led by people with lived experience, but it's endorsed by the colleges, so that when someone goes to the GP and goes, what's this piece of paper or what's this thing that you've got? They go, actually, it's endorsed by the Royal College of GPs, or actually it's endorsed by your state government. So it's giving consumers and equipping them with the power to get the quality care they deserve, because at the moment they're not. Now, this all sounds great. What are some of the lessons from this equally well? Firstly, some of the challenges are this churn. There's always, chief executives change, your champions change, etc. Roughly in systems, every 5 years, a senior position moves on. So if you've got 100 partners, that's 20 you've got to re-educate or re-inculcate about why your organisation signed up to this. The other problem is there's difference in organisational capability and capacity. Organisations go through periods of churn and chief executives and reorganisation, so their capability to make any reform is really quite limited. And that part of that is that patience and perseverance as well. And I talked about the organisational capacity, and I can't even see that, but the limits of the collective, I can't even read that from here, but you guys hopefully can. But that's the challenge, is the limits of collective connections. If you have a collective impact approach, there's just only so many people you can have a viable, meaningful connection to. Dunbar's number of social psychology says 5 close connections, 15 decent ones, and there's those numbers there. So when you're managing and trying to keep the collective together and working together, you need a backbone team to keep it going. The reflection is this is a medium-term race, a middle-distance race. I don't say marathon because no one does marathons, that's too overwhelming. It's a middle distance race, and I think it's a 5 or 10 year project to get these changed. So the perseverance, being that continual, earworm in terms of saying, what are you doing with this? Can we help you? Being there presently. The importance of shared activity. It's great to communicate, it's great to do these sorts of things, but if you have a shared goal, it's so much better, if you want a collective approach, to actually do things together. Like, why are we meeting together? Why are we having this? It's because we're actually doing something together with an end product. It's so important for building a sense of collective and coordination. And the final one is that communication, connection, and commitment. You really have to keep communicating and keep really the vision alive and keep telling the rationale. Why are we doing this? How and examples of success, and also communicating across the collective. And so we have conferences every year where we have Showcase of Excellence. Please go to our website, which is equallywell.org.au. There's a few things, and you'll give examples of, firstly, a narrative literature review. If you want to have a look at this national consensus statement, that's all up there, as well as other resources. And the other really important thing is our conference. We have a virtual conference in Australia, but it's an international conference and it's free because we're funded from the federal government. So please jump on equallywell.org.au and register. It'll make our stats look good, download some of our stuff, but connect. We also have an international collaborative learning network with colleagues from about 12 countries, and if your country is not part of that and you're interested in being part of this international movement, I'd love to hear from you today or from email. All the details are on my thing. So how do we respond? How do we deal with difficult situations in a fragmented service? Well, you walk, you chew gum and you juggle at the same time, and you do it collectively. Thank you.
Thank you so much, Russell. That's been very helpful. And we will have an opportunity to ask questions later on, of course. And I'm looking also to my very helpful support staff here from IFIC. If any of the others have turned up, okay. So we'll sort that out. But now we come to Brian. Brian, very welcome, and the floor is yours.
Thank you. I'll just wait for the poster just to upload. There we go. So hello, my name is Brian. I'm a PhD researcher based in the Ageing Research Centre, University of Limerick in the Midwest of Ireland. I am doing a PhD focusing on older adults' experiences of integrated care when transitioning from the emergency department to the community. Why is this important? Well, in Ireland, we have the fastest ageing population in Europe. Our healthcare system in the future is going to come under huge demand for our services. We also know that older adults transitioning from ED to the community often experience adverse outcomes, such as deconditioning, risk of readmission, etc. This poster today is looking at the experiences of older adults transitioning from the ED to community. So we looked at older adults' experiences when they transitioned directly from the emergency department to the community in any home. This qualitative evidence synthesis wasn't sized as a meta-ethnography, so we viewed over 4,000 articles from various countries. Within that, we included 9 studies in our final inclusion criteria, and they come from 6 different countries worldwide, taking consideration of over 400 older adults' experiences of transitional care from ED to community. So what do we find? So I think the results from this weren't surprising to us. So in terms of the themes, we generated 4 themes. Those themes to me were quite strong. So the first theme, that older adults, when transitioning from the ED to community, often experience fragmented care. So when an old adult is discharged from the ED to community, they often experience where their care is stopped when they go home to the community, or often they get a delay to diagnostics, a delay to getting treatment, a delay to getting follow-up. And this in turn led to generation of a further theme of older adults' risk of readmission to hospital. So older adults who discharge home from the ED to community are often a higher risk of representing themselves back to the ED due to lack of services available in the community. Another theme identified was poor communication to older adults in the community. So older adults who are discharged from the ED often experience lack of communication to their symptom management, to reason for admission, or also professionals working in the ED often use the wrong style of communication for older adults. So, for example, in this study, it was highlighted that older adults often can receive verbal communication. However, when they go home, they cannot retain or recall the information. So hence, they lose the awareness or information to what treatment or what follow-up is organised for them in the hospital. And the last thing was symptom recurrence. So older adults who discharge home from the ED community often experience symptom recurrence. So symptom recurrence can also have external or other factors that may impact the older adults managing at home, to include impact on their quality of life, impact on managing daily function at home, impact on, care or relationship, and also symptom recurrence also leads the older adults returning the ED again. So findings, I think, are no surprise to any of us. In terms of the healthcare system, we need to align care between the ED to community to ensure that older adults receive their follow-up, their diagnosis, their treatment continuation when they're discharged home. Also looking at style of communication to ensure that older adults receive the right method and the right style of communication to address their needs within the ED. So moving on from this, my next further study is looking at trialling integrated care service within the Midwest of Ireland in order to meet the needs of the older people. Thank you.
Thank you so much, Brian. That's excellent. And we've been joined on the panel now by Sophiya and Matic. Matic, can I ask Sophiya first to present? Is that okay? Sophiya is next, and then we come to Matic. And can I also ask, I know we have very helpful IT personnel in the room. Would you be so kind to be able to show us the presentation as well, because we can't see it here in the front? That would be fantastic. So, Sophiya.
Thank you. Hi, everyone. My name is Sophiya Garasia, and I am from Ontario, Canada. And I am a postdoctoral fellow at University of Toronto. I'm part of an embedded postdoctoral fellowship program called OHT, Ontario Health Team Impact Fellowship Program, where we're embedded within Ontario health teams across Ontario. So Ontario health teams came about in 2019 when new teams were made across the province that would provide local care to patients in the community. So I am part of Central West OHT. It's one of the 51 OHTs. It's in Southern Ontario, and it has an attributed population of about 970,000 people. So we're one of the 2 largest OHTs. Our priority since 2019 has been older adults, so I'm glad that I'm following Brian's presentation. And we are a very diverse community as well. So given the problems that we face, we decided to create a program for older adults that are experiencing frailty. Our data showed that they are experiencing a lot of barriers to accessing care. We looked at the literature and we saw that lack of access to the right services at the right time would lead to higher emergency department visits and extended length of stay, and that would be problematic to older adults, of course, to their families, as well as to the healthcare system, given the higher costs. And two large barriers that impact the alternate level of care, so that's the extended amount of care that you are given at hospitals, include lack of connectedness to existing community supports. So our population face a lot of barriers with technology, with language, which hinder their ability to access services. And also another barrier was a delayed transition due to insufficient resources for behavioral patients at alternative sites. So these are high need patients that a lot of times, a lot of community organizations did not have the capacity to support, and it was also unsafe for them to go at home, so they would remain in hospitals. Also, a lot of healthcare, as we've heard today, is provided fragmentedly. Likewise, in Ontario, that was the case. It's provided by single body systems, and to provide care to people with multi-comorbidities, with complex problems such as frailty, a more integrated approach was needed. And we focused on older adults experiencing frailty, not just looking at the physical symptoms, but also mental and cognitive symptoms as well. And lastly, data showed that there was a lack of support for caregivers that were overwhelmingly feeling burdened. So we needed a program that supports them as well. So to solve these problems that we saw from our data, from the literature, we decided to create a program for older adults experiencing frailty. It's a home-based, primary care-based model. And we decided to do this in co-design with individuals who would be the users, so with patients, with caregivers, community organizations, are some groups that we involved in doing this work. So our first step, and I really apologize for the text being small, I didn't realize I would be presenting it here. So I'll just walk you through. So the first step was collecting and analyzing data. So we asked our partners to get us any data that they had that would show us what the problem would be. We accessed administrative data, looking at hospitalization records, looking at home and community care data. And then to get more in-depth information, we also did interviews and engagement sessions to understand where the problems are in the current system, but also to understand where the current strengths are as well. And we did this in co-design, so patients, stakeholders, they were all involved in doing these engagement sessions and creating the questions for the interviews. And from that, we created a problem statement using roots analysis, which highlighted what our problem was, and then we based off all of our design to solve that problem. So we segmented the population of older adults going from low risk to high risk, and we created different change ideas for each of those segments. So for the high need population, the program that I'm about to present, that's for the high need individuals. And we created that in co-design as well, so that involved designing the program, determining the eligibility criteria, who would be involved, who would take over the program and running it, and creating promotional material for the program as well. So this is an outline, a draft of the program. So how we've designed it is that there'll be a referral source. We're thinking of having patients that come in from emergency departments. So these are people who are going to hospitals for 6 or more times in a month. So they're, again, high need individuals. They'll go through eligibility assessment by a nurse practitioner. If deemed eligible, they will have a coordinated care plan that will be established from a care team. So now, not only will they receive services that are provided by providers in silo, but they'll work as one coordinated team to provide services to the people involved in the program. And that will include social workers, physiotherapists, a nurse practitioner, a physician, a navigator. And then they'll go through the program and be reassessed at different points. If they're deemed to be better, they will be looped back to their primary care provider, or if not, they'll continue in the program. And if those that were deemed ineligible for the program, then there will be a care navigator that will help them loop to the correct providers. So right now, where we're at this stage is we've designed this program. It's in the pilot stage. So we're piloting this with 20 individuals from the community, and then we're hoping to scale this up after we do an evaluation. And our evaluation will be based on the quadruple aims. Certain indicators that we'll be looking at are here on the screen. So that include looking at case studies, looking at the frailty score, looking at number of patients that are entering from different streams. So we're interested in having patients not only coming in from the hospital, but we're also taking an equity lens and looking at patients and including patients that come from low socioeconomic status. Improving provider experience is another criteria we're looking at, improving patient and caregiver experience. So we're hoping to have this program be available not just in English, but in other languages as well. And we hope to evaluate what the impact of that is. And then lastly, reducing healthcare costs, so looking at how many hospitalization visits get reduced. With that, I'd like to thank you, and I'll take questions. Thanks.
Thank you, Sophiya. That's really fascinating from Ontario, a really interesting program there from Ontario. We come to our last speaker, and this is Matic. Matic, please, floor is yours.
So good afternoon to everyone. I'm happy to participate in this really interesting session. I mean, oral poster session. So my name is Matic Mihevc. I'm a working GP and PhD student, currently working on SCOOBY project. This is an international project that aims to scale up the integrated care package for patients with arterial hypertension and type 2 diabetes in different healthcare contexts. Well, I come from Slovenia, and Slovenia is a country in Central Europe, and where we achieved high levels of implementation of the integrated care package. However, recently we evaluated the implementation of the package, and we found out that especially elements regarding self-management support and cross-sectional collaborations are not sufficiently implemented. So we asked ourselves how to improve it. And in my poster presentation, I would like to answer on this question, and I would like to answer whether telemonitoring is a right step towards integrated care for the elderly. So we focused specifically for this age group because there is insufficient data that would support such an intervention in this age group. So what we did, we formed a multi-center randomized controlled study which aims to assess the feasibility of this intervention, acceptability for patients and healthcare workers, as well as, of course, clinical effectiveness and cost effectiveness. So first, we somehow managed to came up with a protocol that would be sufficient for the healthcare leaders, patients, and of course GPs working in primary care. So we employed different stakeholders in this process, and then we chose the different healthcare centers that would participate in such an intervention. So what we actually did is we just supplemented standard care with the addition of telemonitoring, meaning that also intervention group received standard care, but there was an addition of telemonitoring for the management of their hypertension and type 2 diabetes. And then we randomized those patients into groups. One was, of course, the control group, and the other one, the intervention group, and we followed up those patients for 1 year. And we actually aimed for a reduction in systolic blood pressure for at least 10 millimeters of mercury, and a reduction in glycated hemoglobin for at least 0.5%, because we currently think that this is clinically relevant for us. So what we found out after 12 months is exactly what we wanted to find out. So the reduction in systolic blood pressure was, I think, 9.7 on average, plus the reduction in glycated hemoglobin, it was minus 0.7. Of course, this is relative to the standard care. So we were quite impressed with these results. Well, of course, we also found out that the telemonitoring is feasible in primary care centers, and we also evaluated acceptability, which is quite, let's say, complex syntax for us and paradigm to investigate. So I did not report those results in the poster. However, we performed 30 in-depth interviews with all participating patients. And what we actually found out is that patients, they really love it. You know, you give them a questionnaire and you ask them, and maybe you structure the questionnaire and they just love it. But then you do an in-depth interviews and then you see that there are quite a lot of barriers that cannot be captured by a simple questionnaire. So if I ask or answer on the question whether this is a right step towards integrated care in this age group, yes, it is, but there are numerous barriers that should be overachieved. So, for example, there's the question of additional burden that we placed on those patients, the burden that we placed on their family members. We also found out that there is a lack of self-management educational programs, and that there is a lack of follow-up programs that would manage to follow those patients in the long term. And maybe if I also address the cost effectiveness of such interventions, this is one of the main reasons why we are not able to scale up those interventions on a large scale. Currently, there are a lot of pilot studies, such as ours, of course, that aims to investigate cost effectiveness. And currently, the better odds are for type 2 diabetes, but not as much for hypertension. This is quite interesting because we are talking about continuity of care of chronic patients. For example, we just performed a quite similar study during the COVID-19 pandemic, and there the cost effectiveness was much more prone towards integration of that kind of intervention because they are implemented for a short term, but on the long term, there's a question whether we should do it or not. So our take-home message would be that maybe there could be different applications of telemonitoring for older people, maybe just for 3-6 months period to achieve the self-management power of telemonitoring. But then we should combine those interventions with different co-interventions, especially with the self-management education interventions, etc. Plus, there is a shortage of GPs, so we also ask how to employ registered nurses to take on telemonitoring skills. So there's a lot of going on, and on that bombshell, I would like to finish my presentation. Thank you.
Thank you so much, Matic. So that leaves us with some real interesting points that the panelists have already raised. I hope we can involve the audience a bit, but I'm not quite sure if we can do that. I think we can, yeah? Is that right? Any questions from the audience? Anything that you wanted to raise, or wanted to ask? And of course, we also bring the panelists in because there have been quite a few overlaps. It's been really fascinating that you looked at the same or similar problems from different angles, isn't it? So any reflections on the side of the panel? Anything that struck you as particularly fascinating from the other presentations? I've got a list of questions here, and they're going to be very critical questions, so you better talk up. Okay, well, I'm going to start you off, and I was wondering, first of all, Russell, I think your program is unusual in the sense that you're really trying to span all three levels. This is going from the macro all the way to the microsystem and micro level. And I was wondering what the policy lessons from that are, because clearly the actors are quite different and the different levels. Are there any generic policy lessons? Okay.
Thanks, Zach. So, I think there's some fundamental governance questions, and the governance question, and we, not by accident, we call ourselves Equally Well, because we look at the equality of all the players, all the people, stakeholders. So the advocate groups, people with lived experience, people with clinical experience, people with place-based experience, carers, as well as, national directors, etc. So our governance sort of includes all of those people, and including our conferences. We have funding so that people with lived experience and carers can attend the conference. So we have government funding so people can travel around Australia for their accommodation, etc. So there's an equality of voice. So often at conferences, it's only the sort of more affluent, privileged people who can attend conferences because they can afford it. This way we get the consumers have an equal voice, as do carers and other people and clinicians who often don't get that. So I think the answer to that is a governance question where we ensure that our governance has that equality where no matter who you are, you have a different voice, but have equal respect to the expertise you bring, whether that's place-based expertise, lived experience expertise, research expertise, leadership expertise, and that's the collective impact model. Collectively, you come to the better solution. It's not simple, but that's our approach. Then you can work across all levels of the system because you're engaging people from each level of the system. You're engaging, we talk about the levers. You're engaging people who have control of the levers at the macro level, at the meso level, and at the consumer level. And so really to be effective, I think you've got to engage equally across each of those systems.
Yeah, thank you so much, Russell. And there is a follow-up question here. I think this goes to you, and it's from Anne Riordan. Professor Roberts, can you comment on your recruitment strategy for inclusion of people with lived experience in this initiative?
Gee, that's a tough one we wrestle with. Certainly, we're careful to, firstly, everyone is paid. Anyone who's recruited, we have funding for paid participation, and at senior level, if they're a chair, they get an executive level payment because we think lived experience has that executive level lived experience. The challenge that we have, to be frank, and we have a number of projects which are co-designed, in fact, are consumer-led. So the consumer committee invites the academics like myself and the senior people in for advice. And then us, the operational people, run the projects. But we really take direction from the consumers themselves, which is quite transformational. The challenge we have is sometimes you get the people who are well positioned as consumer and lived experience advocates, and it's very hard to connect to the people who are marginalised by definition. So we work really hard to not get the same old people who are on every committee and try and reach out to people who have been marginalised and don't normally have a voice. And so that is, it's a major challenge. But quite frankly, it's no different from the challenge of engaging clinicians. You get one clinician voice, it doesn't mean you get every clinician's voice, and the same with policy managers. But it's a major challenge that we wrestle with and what can I say, struggle with all the time. But because our governance has, every co-chair is a person with lived experience and a carer with lived experience, we really do work to try and get maximum engagement. But I don't think, because of the nature of it, we're fully successful, because marginalised, disempowered people by their nature are hard to connect, but we certainly do our best to not just hear the same voices all the time.
Thank you so much. And I wanted to come to Sophiya because something really fascinating struck me there in your presentation, and that is the evaluation part. You spoke about the evaluation at the bottom of the poster as well. And I wondered, you said that you wanted to measure how the care experiences are actually improving, as it were, for those who are in the program. And I just wondered whether you and your team have reflected on the likelihood that those who are in the program are, of course, probably positively inclined towards this program because they're getting an additional service. So I just wondered if there are any reflections on your side. How are you going to filter that out? How are you going to do that methodologically, maybe, or in any other way?
Sure. So we are doing an evaluation of patients, their experiences, as well as providers. And from our experience, even if patients are experiencing positive things, they're more likely to say negative components of the program. So we weren't too worried about patients being a part of this program and only talking about the positive features of it. But we are thinking of evaluating at different time points. So starting from the beginning of the program, talking about how their care is currently with their provider, and then talking about it at different points into the program all the way up until the end. And then if a patient decides to leave the program, also why did they leave the program? So if they're having a negative experience, perhaps they do. But we are hoping to take an unbiased perspective as much as possible by the questions that we ask, by having people surveying be outside of our program and telling them that their answers will not influence their care at all. So hoping through those methods that we get as honest answers as possible.
That's really fascinating because it contrasts slightly with Matic's presentation, because I think you're favoring and championing a bit of a randomized, controlled kind of like design there, which is very ambitious, of course, with 63 people. But following up from Sophia's answer, I was going to ask you, Matic, the telemonitoring of the elderly population, I wasn't quite sure whether what is the actually added value or the added intervention, as it were. Are you telemonitoring them more often? Is this the frequency, or is it actually the consultation? Because if anybody gets an additional consultation, then clearly the frailty is going down, but that doesn't necessarily require telemonitoring. So I just wondered if you could tell us more about that.
So I didn't have time to elaborate this more clearly. So we actually gave each patient monitors for blood pressure, blood glucose. Some of them, they didn't have it before. So for them, they were motivated to get the monitors, plus they also got an additional phone. So actually this was a synchronous type of telemonitoring, and meaning that the patient took the measurement, and those measurements directly went to telemonitoring center. On the other side, actually, I was the one in the telemonitoring center, so maybe this was an additional value because I was a GP. If you look around the world, usually those are nurses. So maybe an additional value was a GP being a telemedicine center coordinator, plus this synchronous response time, which they really appreciate. They needed to measure their blood pressure 2 times per week. For them, those were Mondays and Wednesdays, and they also needed to perform the blood glucose measurement each month. But it was like that, the protocol was made using alarms, meaning if the value was okay, it was just a green alarm, and they needed to repeat the measurement next month. But in case that their value was out of range, they needed to do the 3-pair profile, meaning 6 times values, So to answer your question, what was the additional value? I think, yes, maybe being supervised, plus, each month I gave them some feedback. I also incorporated positive feedback in terms of regular exercise, diet. So I think that's the question, that's the answer. Plus, telemonitoring also facilitates all different elements in the integrated care package. They could share the data with other specialists. They were provided with monitors, etc. So.
That's really fascinating, and disentangling the effect from the observation effect is, of course, quite tricky there, isn't it? I come back to Russell, because there's a really interesting question here from Anne van den Boyk regarding the equally well. Sorry, before I ask that question, those of you who are in the audience and speak French, feel free, please, to type your question in French into the app. I promise I won't read it out, so I won't torture you with my French, but we can pass that on, of course, to Céline, okay? So Anne van den Boyk is asking, regarding the Equally Well Australia program, how do you experience ideas and values, etc., get across the different levels? So it's really a dissemination and learning across question. Is there a person or organization who has this responsibility? So who carries that responsibility?
That's another great question. You know, our mantra is who is equally well, and we always say you are. You know, what do? You do what you can, when you can, where you can. And that's thank you for the question, because that's something I didn't elucidate on in my presentation. This just can't happen. So in fact, we are just, in response to a fragmented system, our argument is we're not another fragment. We're not a service provider in an already fragmented, siloed system. We're a backbone team to connect all the different fragments. So yes, I think essential to a collective impact approach, and there's 3 at the moment, maybe 4. Hopefully Canada's going to join us soon. You know, the UK, New Zealand and Australia, and we work together very closely. But each has a backbone team. So it does need, I suppose, an administrative function, and we try and carry the values and disseminate those values. But we require all of our 100 partners to sign up to those values of equality. So it's a fantastic question, because it is a collective impact approach. It's a massive problem, it's a complicated system, and everybody needs to do their bit. But still, there needs someone, like, as I talked about, when chief executives move, when senior policy officers move, there needs to be someone to carry that narrative of, like, why did you sign up to this? What are we trying to do? What's the problem and what's your connection? And that's a very small backbone team that just keeps that collective alive, and that's one of the 5 principles of a collective impact approach to service reform.
Fantastic. Thank you so much, Russell. And that brings us to a close. So I just want to say a big thank you to all of our panelists. And if they might stick around a bit, if you still have questions, to approach them after the event. But if you would be so kind to show your appreciation for our panelists now. Thank you.